Speaker view very good. Thank you. Madam, can we start the meeting?
Sure, sir. Please, sir.
Sure. Good morning, everyone. First of all, let me thank our Chancellor, Director, and our Dean of Saveetha Medical College for their encouragement to our department for doing such academic programs consistently. This is our 7th program in September. We have been doing every September some program or other. It's the 7th program. And I'm extremely happy on behalf of the organizing committee to welcome Dr. Saveetha Rajesh, Director, Saveetha Medical College, who graciously accepted to inaugurate this web meet, and also welcome our Dean and all the speakers of the day who were able to come in and join us for this meeting, and all the delegates. Tinnitus is one of the vexing problems, not only for the practicing physician, also as well as the patient. And because of this situation of the inner ear inside the bone of the toughest bone in the body, it is resisting all our efforts to understand it. So the aim of today's program is to share the people who are doing some work on tinnitus, to share their experiences with all of us. So with this brief welcome address, I invite Dr. Saveetha Rajesh to inaugurate this web meet. Over to you, madam.
Thank you, sir. Nice to see all of you on Zoom, and good morning to all the delegates, all the faculty members, international, national, and our department faculty members who have joined together today for the discussion and for the web meet on tinnitus. On behalf of Saveetha Medical College, I take immense pleasure in welcoming all the faculty members. We have an international faculty member from Wales joining us, and then several national and faculty members from in and around Chennai as well. So a warm and hearty welcome to each and everyone. And I'm very happy that the Department of ENT has been proactive. It is one of the most active departments academically in our institution since the inception of our college in 2008. And they have been forerunners. And in spite of this being a pandemic and we are all in a very stressful situation, the department has taken up to conduct the web meet in the month of September when we celebrate the Deafness Week and almost every year. So I'm very, very happy that the department has taken up the initiative to conduct the International Tinnitus webinar with so many of the stalwart faculty. And as Dr. Srinivasan, head of the department, sir, said, tinnitus is like, it's like somebody living in our ear always. It's like something like schizophrenia with the crunching noise, and it's really disturbing for the patient, one who suffer from it. And I'm sure today's meeting on tinnitus with the management from the neurologist perspective, from several other perspectives, I'm sure will be a great boon to all the students, all the postgraduates, and as well as the interns who are all listening to this webinar. I'm sure this will be a great learning experience, and I once again congratulate the department for their effort to conduct this webinar in spite of the situation around us. I hope all of you have a very fruitful day today. All the very best to all of you. Thank you, and happy Deafness Week. Yeah, thank you, sir. Sir, you are muted.
Oh, sorry. Thank you, Dr. Saveetha, for your encouraging words, and I thank Dean also, who has taken a vow of silence. He told me before coming.
No, not that. Congratulations, and please proceed. We don't want to, break the continuous flow. Please
Thank you.
Thank you.
Now Thank you, sir. Now I ask the MC to take over. Dr. Indu, please. those of you who are there can, all the dignitaries who have come here can, take your leave, and thank you very much for coming.
Thank you, sir. Wish you a very happy day, sir. Thank you, sir. Take care.
Ma'am. Thank you, ma'am.
Thank you, Ram, for coming.
Thank you, sir. I think I'll be there in this.
Sure.
Good morning, everyone. On behalf of the organizing committee, I welcome all delegates to SAVIN 2020 International Tinnitus Web Meet conducted by Department of Otorhinolaryngology, Head and Neck Surgery, Saveetha Medical College, Chennai. Thank you, Director Ma'am, for the welcome address. We, the organizing committee of SAVIN 2020, would like to offer a sincere gratitude to our respected Chancellor, Dr. N.M. Veerayan Sir, Director Dr. Saveetha Rajesh Madam, Dean Dr. J. Damodaran Sir, all members of the advisory committee. Our speakers for today, Dr. Ramesh Rohiwal Sir, Dr. Ashish Chandrakant Mohide Sir, Dr. Ramachandran Vishwanathan Sir, Dr. Deepak Rajendra Kumar Sir, Ms. Sharanya Gunalan Ma'am, and delegates present here. I would also like to thank Pharmacare Division of Sun Pharma Pharmaceutical Industries Limited, Mr. Mahendra, Deputy General Manager, Mr. Sundar, Sales Manager, and Mr. Shivan Pushparaj, Regional Manager, Chennai. Before we commence the program, I would like to inform you that if you have any questions during the presentation, please enter your questions in the question box available next to the video. They will be answered after the end of each presentation. Thank you. The first talk of today's program is Pathogenesis and Evaluation of Tinnitus by Dr. Ramesh Rohiwal Sir, who did his MBBS and MS at BJ Medical College, Pune in 1983. He is the Director and Senior Consultant at ENT Hospital and Vertigo Clinic, Aurangabad, former Professor at MGM Medical College, Aurangabad, former Honorary Senior Consultant at Seth Manlal Youth Hospital, and United Sigma. He's a visiting consultant at Vertigo Clinic, Columbia Asia Hospital, Pune. He has published several papers and has presented and conducted vertigo update workshops and conferences at national and state level. He was the founder president of AOI Aurangabad branch and past president of IMA Aurangabad branch. He has been awarded a Best President Award at both state and national IMA conferences. Now I request Dr. Shobha ma'am, Professor, Department of Otorhinolaryngology and Head and Neck Surgery, Saveetha Medical College Hospital, to chair the session. Thank you.
Good morning, all. I now invite Dr. Ramesha to start the speech. Sir, now you can take over, sir.
Hello, am I audible?
Yes, sir, you're audible, sir.
Start sharing my screen.
Yes, sir.
My presentation is seen? Hello?
Yes, sir, it's seen, sir.
Yeah. Good morning, everybody. At the very outset, my sincere thanks to Team 72020 for inviting me for this unique session on tinnitus. My talk will be in two parts. In first part, I'll try to cover the pathogenesis and evaluation of the patients. And in my second half of the talk, I will go for the management part of it. So tinnitus is a complaint for which the patient seeks medical advice next to the headache. What are the definitions? The basic definition of tinnitus is derived from the Latin word tinere, which reflects the condition in which patient experiences a ringing, buzzing, or hissing sound, auditory sensation, in the absence of any external sound. So there is no external sound, but the still patient feels that he is hearing some sound. What are the types? The types of the tinnitus can be either objective or subjective. In objective type of tinnitus, the patient tinnitus can be heard by the clinician. And in the subjective tinnitus, which is most common, the sound is not heard by the clinician, but the patient is hearing the sound. In subjective tinnitus, the patient has got his own way of describing the symptom. He may say that he is getting noise in the ear, or he can say there is a noise in the head. Depending on the location, it can be either tinnitus aureum or tinnitus cerebri. As I have told you, in objective tinnitus, it is a rare condition which refers to the condition in which there is a real sound which is generated by some internal biological activity, like a vascular turbulence or a pulsation or a spasm of the muscle in the middle ear or eustachian tube or the soft palate. We'll come to the details afterwards. Subjective tinnitus is a very common type, and there is a phantom ringing or buzzing sensation that occurs in absence of the sound. In objective tinnitus, there is actual tinnitus which can be heard. In subjective tinnitus, there is a tinnitus, but it cannot be heard by the clinician. So there is a difference between these two. Lot of classifications all over world, they have been tried to classify the subjective tinnitus in different categories and different groups, depending on the site of the lesion, patient's description about the tinnitus, clinician's observation, the perceptual characteristics of the tinnitus, causation, the neurophysiological characteristics, responses to the treatment, and combination of all these factors together. But till date, there is no consensus about the classification, and no classification is accepted worldwide. When a sound reaches the ear, it is transformed into the electrical information in cochlea. The sound energy is converted into electrical energy, and via cochlear nerve, it will be going to the brainstem, reaching the auditory centers within the temporal lobe of the both hemispheres. The other parts of the brain, they are also involved in our memory for that particular sound or for an emotional reaction. A classical example about the memory of the sound is a school bell ringing. Everybody in the childhood has experienced this. And the sound which reaches the ear about the ear bell, it has got some memories. There are some emotional reactions when there is a problem because of the sound. And as I have told you, we have got a memory about the sound. It is shown in this table. When sound from periphery is reaching in auditory brainstem, there is a subconscious monitoring going on, and the auditory cortex, it has got its own way of interpretation. And there are many neuronal circuits within the brain that will give, like amygdala, it is related with the emotions. There is an autonomic nervous system which induces the fight and flight responses. So this is a complex process through which a sound is perceived in the brain. Before we go to the details about the tinnitus, let me tell you a few things. Any patient who is coming for the treatment of the tinnitus, he has got a fixed notion in the mind that nothing can be done. There is no one who is going to understand their tinnitus. But the very fact that he or she has reached to you, it means that they have a belief in the mind that there is someone somewhere and there is some hope. Clinicians also have many negative beliefs. The first and foremost belief that they have is they cannot help the patient. They don't have proper training which is required to diagnose correctly the etiology of the tinnitus and manage accordingly. And third and foremost important thing is that whatever they do, the patient is going to spend money, and if the patient is in the insurance plans, the money is not going to get reimbursed. As compared to the surgical procedures which we do, the money which comes through the tinnitus patient is less, and that may be the another reason why clinicians are reluctant to treat the tinnitus patient. And they try to avoid treating patients, but this should not be the scene. I've seen many clinicians telling the patient that nothing can be done for your tinnitus and you have to live with your tinnitus. This is utterly wrong attitude, because the poor patient has come to you with hopes, and it is your duty as a clinician to do something which will help him. So what is essential? The most essential thing is to have a knowledge, and we should be perceived as a knowledgeable professionals. You have to demonstrate that you understand tinnitus. You have to provide a clear therapy plan to the patient. Whatever, to best of your clinical knowledge and judgment you derive, you have to tell the patient that such and such things can be done. Foremost important is be sympathetic to the patient, because it is observed that most of the patients of the tinnitus, they have got some psychological problems like anxiety, depression, sometimes bipolar disorders, etc. That's why you have to be very sympathetic with the patient and try to understand what are his problems. and you try to show that you are sincerely caring about the patient and assure him that there is a reasonable hope in the treatment. You can start the discussion like patient's tinnitus. You explain him that if there is a tinnitus, you get tense, you give more attention to your tinnitus, and your tinnitus gets worsened, and then you become more tense and get worried about it. Let me tell you, whenever there is a tinnitus, a patient has a tinnitus, he has got a fixed concept in the mind that he has a brain tumor. It's our duty to take out this myth from the patient's mind. What are other myths about the tinnitus? Patients feel that it is incurable. Those who have it, they have hearing loss, and that's why they are getting affected by the tinnitus. Patients feel that tinnitus causes deafness, which is not true in many cases. They feel that hearing aids are of no help in relieving the tinnitus. This we have to explain them thoroughly, because nowadays, with the advances in electronics, so many different categories of hearing aids. I'll be coming to that part again. We have got masking devices, like masking hearing aids also are available. Patients have got belief in the mind that the tinnitus caused only by loud sound or music or by using earbuds. About the loud music or the sound, it's our duty as an ENT doctor to explain to the patient that 60 dB and not more than 60 minutes in a day is a desirable sort of a use of a equipment for listening to the music. Some people, they have got a feeling in the mind that tinnitus is an illusion, which is not. When it is there, it has to be treated. We have to tell patients about the fact of the tinnitus. You have to explain them the scientific things, explain them the mechanism of hearing, where can be the fault, what can be done. Everything has to be explained. You have to spend a lot of time in counseling the patient, explaining them the real scientific things about the tinnitus. This can be effectively diagnosed correctly, and it can be treated with the proper modalities of treatment that are available to us. There are a lot of models which have been suggested for tinnitus because the exact cause is not known. The psychological factors are considered. That's why there is a cognitive model where the patient is thinking in an inappropriate way about the tinnitus. Patient fails to get habituated to the bothersome tinnitus, and patient is many times not able to shift attention from the tinnitus. Patient is not able to learn how to respond to the tinnitus. So that's why the role of a counselor, a psychologist, it comes. The patient has to be treated as a whole and not only a cause in the ear. Different theories which have been suggested about genesis of the tinnitus, that there is some age between a normal and the absent hair cells, and then there is the subsequent troubles in the neuronal activities. There's one theory which was very popular, is a decoupling of the sternocilia between the hair cells and the tectorial membrane. Another postulate was there is a interneuronal synchrony. Lot of connections in the central nervous system and within the brain. Because of that, there are a lot of disturbances and the patient is getting tinnitus. There are spontaneous autoacoustic emissions and they cause tinnitus. One theory was there is a hyperactivity of dorsal cochlear nucleus. All these postulates, they have been investigated by different group of people, those who are working in this particular field of tinnitus. And the research is continuously going on about different things. Why we are so firm about that there is an involvement of brainstem and cortex in the involvement of the tinnitus. Even if a cochlear nerve section is done, the tinnitus is not completely abolished. That clearly means that there is something definitely responsible other than cochlea for the generation of the tinnitus. A very interesting finding, a patient of a tinnitus, when a masking is done either on the ipsilateral side or even in the contralateral side, it helps the patient of a tinnitus. If it is only located, pathology is only located in the ear, the masking on the same side should help. There is no role of a contralateral side of masking done in that patient. There is one interesting paper which says that patient with the tinnitus in the right ear, if masking is done, the tinnitus is heard in the left ear. All these observations, they tell us that there is definitely a role of brainstem and cortex in generation of the tinnitus. Now it's your duty to do the evaluation part of the treatment. The aim is to identify if there is a significant medical problem. We have to determine the severity in the patient, find out if there is a treatable cause. A detailed history of the patient is to be taken. To go for a physical examination, including examination of the ear, CVS, and neurological examination. Audiogram is first foremost essential thing, and it has been observed that in younger age group there is a noise-induced hearing loss as compared to the elderly patient. Those who are suffering from tinnitus, there is a presbyacusis. It is a sensorineural loss as per aging. Now there is some concept like tinnatogram. I'll explain about it in the detail, wherein a frequency and loudness, they are studied. American Tinnitus Association, they have got a lot of protocols about working out in cases of the tinnitus. You can go to their website and find out more information. What are the protocols? There are many questionnaires, handicap questionnaires, the behavioral questionnaires, different things are there. And we have to go in detail and try to find out what is exactly wrong with the patient. In history, we are going to look for what is the quality of the tinnitus, whether it is unilateral or bilateral. If it is pulsatile, it can be vascular in nature. Sometimes you get patients with clicking or tapping type of tinnitus, which is very common in myoclonus of the middle ear or palate. You have to watch for hearing loss by simply doing tuning fork test. You can start the examination. You have to inquire about whether the patient has got any hyperacusis. Either there is any misophobia. Some patients, they have got a habit of responding fearfully to the sound which is heard. And of course, there is history about phonophobia, which you have to rule out. If it is a low roaring type of a tinnitus, it is usually of low frequency. If it is a hissing type, it is a broad loss or mid frequencies. The ringing or whistling tinnitus is typically seen in the high frequency hearing loss. And complex sounds, patients, they say that as if there is some music going on in the ear, or there are complex sounds. The psychiatric disorders or temporal bone tumors, they need to be ruled out. In the history, we have to go like we do history taking in the all patients. Try to find out about the onset, when it started, duration, for how long it is going on. If the tinnitus is of a longer duration, it is less likely to have any serious cause. You have to inquire about the associated symptoms like diminished hearing, hyperacusis or phonophobia, dysphonia. Ask for the history of trauma, head injury or whiplash injury, diabetes, blood pressure, anemia, thyroid disorders. We have to definitely inquire about the exposure to the noise. If there is any diurnal pattern, the tinnitus usually it is more in the night when the ambient sound is less. Is there any association with the sodium intake? Tinnitus increasing with the sodium intake gives us a clue about Meniere's disease. And hyperacusis with tinnitus, of course, is again endoempatic hydrops or Meniere's disease. Watch for the facial weakness. Ask about diplopia, headache, either if there is a sensory or motor deficit or if there are any other neurological problems. The drugs are very important. Usually elderly patients which present to us with the tinnitus, they are taking a lot of medicines. Commonest is aspirin, and it is routinely prescribed for cardiac disorders, myocardial infarctions, hemiplegia. Aspirin is known to be most notorious for producing tinnitus in patients. The same thing is true about non-steroidal anti-inflammatory drugs. Antibiotics like aminoglycosides, chloramphenicol, erythromycin, tetracycline, vancomycin, vibramycin, they are known to cause tinnitus. To inquire about any antiviral or chemotherapeutic agents if patient is taking, bleomycin, interferon, pegylated interferon is the alpha 2b, cisplatin, methotrexate. These all drugs are known to produce tinnitus. Ask about history of ototoxic drugs like mercury, arsenic, lead. These heavy metal molecules, they are not used more in allopathy practice, but we come across a lot of patients, those who are taking homeopathy treatment for chronic ailments. And homeopathy people, they are using heavy metals very routinely. You must have seen recently, arsenic album has been widely publicized in the COVID epidemic recently. And patients, those who are on homeopathic treatment, they have been told that homeopathic treatment has got no side effect. It has got only effect. You have to ask about the history of diuretics if patient is taking like furosemide. Other drugs like chloroquine, quinine, quinidine, and now addition to the list is hydroxyquinone. All these drugs, they are known to cause tinnitus. Now to go for a physical examination. In the otological examination, we'll see for the external auditory canal if there is any wax in the ear. Tympanic membrane needs to be seen. If there is any secretory otitis media or a glomus tumor even can be seen when you see the tympanic membrane. Try to see the middle ear also findings. Watch for if there are any twitching movements. The tympanic membrane movements with the respiration. It will give us a clue about the patulous eustachian tube which causes tinnitus. There is a palatal twitching which can be best observed by using nasopharyngoscope for myoclonus. Patient complains of typical clicking sort of a tinnitus when he is trying to eat or swallow. Tuning fork test, as I have told you, Weber and Rene, where to do, try to evaluate about the hearing loss. If there is any pulsatile tinnitus, try to observe if there is any variation of the symptom when there is a head movement, or try to do gentle neck compression. Remember, both sides of the neck or both region of the carotid, they are not to be pressed simultaneously. To do auscultation of head, neck, and external auditory canal with the insert type of a probe, it can be done. Ophthalmological examination is essential to rule out papilloedema, which is very common in benign raised intracranial tension. The sympathetic attitude and spending more time with the patient, try to find out if there is any anxiety, depressive symptoms, if there are any sleep disturbances. About the sleep disturbances, it is said that it is difficult to establish the cause and effect relationship, and there comes the role of a counselor. Now, something about this tinnitus. This is something where high frequency headphones are used, and using algorithmic software technology from 1000 hertz to 15,000 hertz in low, mid, and high frequencies. All frequencies are studied, and the pitch and the loudness of the sound is established. In a tinnitus tonal audiometry, there is a tinnitus loudness, which is a 5-point scale, and there is something which is called as a tinnitus masking, where an audiologist try to find out the exact frequency at which there is a tinnitus. When I'll tell about the treatment by this particular modality of treatment, I'll come to more details about this particular entity. As I told you, just examining the middle ear, if you see something like this, you can see a pulsatile glomus. Doing investigations in patients can give us a clue like a vestibular schwannoma, which is very common, is a long-standing sort of a tinnitus and hearing loss. You have to see about the other patient. So with a note that my sincere thanks to Dr. K. Srinivasan and our organizing team of the 72020. My sincere thanks to Dr. Prahlada from Chitradurg, who rather got me involved into this event. My sincere thanks to Dr. Srinivas Dorasala of Bangalore, Managing Director of Cyclops, providing me a lot of inputs about the presentation, and Professor Mohammad Shanawaz, who is also very instrumental in preparing few things. Thank you very much.
Thank you, sir. Tinnitus is a very difficult topic for both the patient and for the treating physician. Your talk has given a highlight on an important part of it, that is the pathophysiology. Still now, we have not received any input about questions, sir, so we will wind up this session.
Yeah, we can have questions at the end of the session, no problem.
Yes, sir. Still now, nobody has sent any questions. So in case we get, we will invite you for that, sir. Thank you, sir. Thank you for a wonderful speech.
As the previous session winded up earlier than the expected time, we will take a short break for 15 minutes and gather back at 10:55. Thank you.
Good morning. To talk. Dr. Ramesh, you can start, you can join us after 1 hour.
Yeah, no issue.
Dr. Ramesha?
Yes, sir. Good morning, sir. How are you, sir? Good morning, sir. How are you, sir? Yeah?
Hey, start the session. Can we?
Sure, no problem.
Can we start the session?
Sure, sir, no problem.
Okay.
Welcome all. The second talk of the day is Neurologist Perspective to Tinnitus by Dr. Ramesha Tikka, who's a practicing physician, neurologist, currently medical director and managing trustee of RVR Foundation, Rural Health Research Trust, Chennai. He's also the associate professor in the Department of Medicine at Karpatavanagar Institute of Medical Sciences and research guide at Saveetha University. He was trained in neurology with giants both in India and in UK, like Professor Srinivas, Professor Nia, Professor Nick, Professor Sahasra, and he's also the alumni of the prestigious University College of London. I request Professor Dr. Srinivasan Sir, HOD, Department of Otorhinolaryngology and Head and Neck Surgery, Saveetha Medical College and Hospital, to chair the session.
Thank you. Thank you, Dr. Indu. Dr. Ram, known to me for several years now, he is a very good speaker. And I thought there are many causes for tinnitus in central nervous system also. I thought one neurologist to talk of that topic would be a good option. So I have asked Dr. Ramchandran to his talk. Now I request Dr. Ram to start his presentation.
Thank you very much, Professor Srinivasan, for having given me this opportunity to do the presentation. I shall start by sharing my screen. Right. So, firstly, a big thank you to the complete organizing team for having done a wonderful compilation of great topics for the day. It's been as educative to me as it is potentially going to be for all the participants participating in this webinar. Thank you specifically to Dr. Srinivasan, because he had the confidence in me to call me, and I think he was daring enough to have this misadventure as well with me. So the objective of this presentation was to introduce what was the concept of tinnitus and have some theoretical aspects of tinnitus, and then probably an approach to patients, and probably a hint to the future of tinnitus. Now, what has now happened is that Professor Ramesh has very nicely given us a big background, and because of that background, I potentially can go fast forward at various other places. Now, a definition has already been given, but then a clinician definition is a little different. Now, in Mahabharata, there is a story that goes by. If you cannot change the Muhurtam, change Amavasa. That is the concept that is given. So here, the concept is that tinnitus is, of course, a conscious perception of sound. And it is in the absence of a gross auditory stimulus and its relation to it. And is usually described as ringing, humming, buzzing, hissing, clicking or pulsing. And this is what has been a classical definition of tinnitus. But then there is an added component to it, which is that and is associated with a subjective reaction. So you have two components as far as tinnitus is concerned. One, a concept of perception. Two, a concept of reaction. So a definition of tinnitus of late has two components now, a perceptive component and a subjective reaction. And a perceptive component has what has been divided into gross auditory stimulus and not so gross, and that's what's called as subjective perception or subjective tinnitus. So why is it that we are picking on such small words in order to make a definition or work upon it? The reason is that tinnitus is a symptom, not a diagnosis. And because it is a symptom, the etiologies are varied. And because etiologies are varied, the pathogenesis could potentially be varied as well. And hence, a misclassification of what is perceived as tinnitus, if is included in a study, then the chances of detecting an obvious pathology when the conditions are scattered within that symptomatology then becomes very, very, very difficult to match. It's basically, you will not be able to distinguish noise from sound, and therefore we need to be as precise as possible, both in defining and including patients in our studies, so as to be sure that we are dealing with a homogeneous population. The next surprising thing is, why should we have a one-day program for a symptom? The obvious answer is, if you don't know much about something, about it, you will know about it at some point in time. Tinnitus is a very common problem. There are no drugs for treatment of tinnitus as a symptom. Around 10 to 20% of the adult population is exposed to it. 33% of elderly complain of tinnitus. And it's like headaches. It's got a very large placebo effect. Anything that you give may be associated with a relief for a short period of time, only to come back again to haunt you. And when you really sit down with patients and talk with them, none of them are happy with the treatment that is offered. Why? The kind of treatment that we offer is for the reaction as of today, not to the suppression of tinnitus itself. We make the patient live in a world of Maya. I mean, the patients invariably are in the world of Maya. We will discuss this subsequently. There is a significant financial burden on the healthcare system and the society. There are no biomarkers or objective measures of tinnitus. Research is not very great. Pathogenesis is not really very well understood. Animal models do not correlate with human studies. And routine equipments for testing ear function is not optimal either. We shall discuss some of these issues while going through the presentation. But then, what causes tinnitus? Now, it's already been discussed that there are two obvious pathways. Now, if we were to understand an auditory pathway and then speculate that irritation of the auditory pathway is the one that is causing seizures and that's causing tinnitus, then it's akin. It's a simple hypothesis. Say, for example, if there is an excitement of the cochlea, more sound impulses, and therefore you perceive that sound. Or if the cochlear nucleus for some reason is stimulated, then potentially you can have a tinnitus. Or if the hypothalamic axis for some reason is sending in an input to the cochlea, thereby stimulating it further, it could potentially result in, or even if the auditory cortex is stimulated, especially the anterior aspect, you can potentially have symptoms of hissing sounds generated. As such, the mechanism for development should exist somewhere around this plane. And if that be the case, then it should be very easy for us to decipher what the problem actually is. The problem, however, is that all these hypotheses are still under investigation. And we have not been able to lay our hands to say that this is exactly what is happening. A lot of confusion. We are actually facing the elephant, and each group, each tinnitus research group is looking at one part of the elephant, but the whole story is yet not revealed. But what about the conditions wherein the reason is very obvious, be it wax blockages, be it middle ear diseases, inner ear diseases, the muscular diseases? Well, this is where objective versus subjective tinnitus comes into play. All these conditions that are now known or associated with tinnitus have an objective component to it. The only issue is that the objective component has got to be verified. Even in a subjective tinnitus, there are cases wherein if we sit down and elicit the proper history, it should potentially be possible to at least decipher in a proportion of patients an objective component. Let's get to it. Well, this is common. I mean, what's neurology up here? I've been tracking ENT, arterial dissections, fibroblascular dysplasia of the internal carotid artery causing narrowing, intracranial aneurysms, AV malformations, dural venous fistula, arteriovenous fistulas, jugular vein abnormalities, venous stenosis, intracranial hypertension with without aqueductal stenosis. All these can present with either hums or a pulsatile tinnitus, which can be verified now with appropriate investigations. Here is a patient with what's called, who presented with a left-sided pulsatile tinnitus, which has been going on for a very long time. Okay. What you see here is that there is a narrowing of a right sigmoid sinus. And this patient, when we press the jugular on the left side, had a reduction in the tinnitus. The angiogram reveals that there is a small block in the right sigmoid sinus. And when you press the right jugular vein, there was an increased volume of tinnitus. Now, this second sign is not very obvious in most patients, but if it is present, please do consider the diagnosis of a sinus stenosis or a venous stenosis. Okay? Why? If the patient is symptomatic and is troubled, the chances are that these patients can be treated well and cured of their tinnitus. Well, Dr. Ramesh also touched this topic of drugs can cause tinnitus. The reason why I want to talk again is because I want to stress that almost any drug that you take can cause tinnitus. And tinnitus need not be caused when the patient is on medication. It can be caused even after it is stopped. It can be caused immediately. It can be caused after prolonged therapy. And therefore, there is nothing that prevents you from suspecting a growing incidence of tinnitus in this world at this point in time. Please understand, just because a drug label does not list tinnitus as a possible side effect, it does not mean that it will not cause tinnitus. Now, I'm going to go through a series of slides, but very fast. The only reason is to show that every drug we normally prescribe has got an ototoxic effect. Number two, many of these drugs can cause tinnitus as well. Right. Gastrointestinal. Now, each of them has got a number by it. One refers to ototoxicity, two refers to tinnitus generation, three to vertigo generating drugs, and four possibly ototoxic. So we are more interested in two, I understand, but then ototoxicity can also lead to tinnitus. One of the things is that drugs have still been poorly investigated as causes for tinnitus. And that is the reason why I want to bring this up. Right, all the cardiovascular drugs that we normally use, especially the diuretic parts, atorvastatin, a very, very commonly used drug, can cause tinnitus, not just nifedipine, which is used by the cardiologist. So if ENT people have got to thank somebody for giving them patients with tinnitus, it is the cardiologist. Don't forget that. ACE inhibitors, ARB blockers, angiotensin II blockers, so on and so forth. Okay, calcium channel blocker is one of the most popularly prescribed calcium channel blocker being amlodipine. Not just, and this is from 2011, and therefore we don't know what that, how much this list has been updated. Respiratory drugs, including a very commonly prescribed drug called chlorpheniramine maleate. Central nervous system drugs, including the whole group of tricyclic antidepressants, which is also used for treatment of tinnitus. Serotonin antagonists, 5-hydroxytryptamines, infectious diseases antibiotics, almost all have nephrotoxic effect to varying degrees. Endocrine drugs, drugs used in OBG, especially hormones as well. Basically, ergometrin is the one that's used during obstetrics. Of course, cytotoxic drugs, which has also been discussed previously as well. Please understand, all your multivitamins, especially hydroxycobalamin, iron, even calcium, is not without side effects. NSAIDs are notorious. We've already discussed that, chloroquine as well. And is used by you and others as well, and dermatology. Now, basically, what is it that I wanted to tell you? Among the cause relationship accepted for tinnitus, exogenous measurable noise producing elements like blood vessels, muscles, joints are important as far as generation of tinnitus is concerned. This could by some means be measured by an external source. There are also issues related to the cochlea itself. Some aspects of it has already been covered by Dr. Ramesh. Drugs through various mechanisms can cause tinnitus and hence has got to be documented in all cases with tinnitus. Metabolic causes has also been described previously, but these factors cause by altering one of the above three mechanisms. So you have a noise, the patient can feel the noise, or the patient feels the noise, which is interpreted as tinnitus. So what about in other cases where there is a hearing loss and no tinnitus? Well, that's okay. Where there is tinnitus persistent even after the eighth nerve is transected, or when the relatively normal hearing, but patients have tinnitus. What is it that you will have to say for these? Which means it is not an aberrant conduction alone of some sound that is present, which for some reason we are unable to detect. But it's something more than what is actually happening in the auditory radiations. Let's get back to basics. What do we call perceived sounds without stimuli? Well, the ENT people will call it as tinnitus. The psychiatric people call it as auditory hallucinations, and we as neurologists call it as seizures. Isn't it surprising that it is for the same perceived sound without a stimuli that we have three different definitions? Well, tinnitus is different. Auditory hallucinations are different. Seizures are different. At least this is what we have all been taught, isn't it? Well, before going on to more controversies, let me just tell you that a study has recently been published in 2017 in JAMA Neurology to find out the prevalence of tinnitus amongst controls and participants with self-reported epilepsy and patients with epilepsy who underwent surgery. And they realized that the prevalence of tinnitus in patients who underwent epilepsy surgery, basically a medial temporal lobe lobectomy, was much, much higher than controls or those with epilepsy. This means one of the most important components that is probably responsible for preventing the generation of tinnitus could be the medial temporal lobe. Now, why is that important? That is where your amygdala is situated. And that's where you have this auditory cortex amygdala connections. And that is what is defined as one of the pathophysiological mechanisms, the central nervous system contribution as far as tinnitus is concerned. There seems to be a reorganization of the brain's tonotopic map following deafferentation. Now, I didn't touch deafferentation on purpose. Deafferentation actually refers to the process of the ganglion cells dying. You know, the inner hair cells are innervated by special synapses called ribbons. And when the inner hair cells per se are sturdy cells, but any noise can potentially give rise to the ganglion cell death, thereby preventing the cochlea from getting afferented. Okay, so the afferent component is lost. So deafferentation results in a change in brain's tonotopic map. There is an increased spontaneous neuronal firing. I mean, the next diagram actually tells you why that happens, but we are not going to discuss that. There is an increased neuronal synchrony, and this word synchrony actually will make many heads sit up. The reason is synchrony happens in seizures. So here is a connection between tinnitus and seizures. Increased neuronal synchrony it's more like epileptogenic. That's what is tinnitus all about. And there is failure of the inhibitory pathways. Now, more than the inhibitory pathways, I mean, I personally would like a word like modulatory pathways, you know. And there is a maladaptive auditory sensory, somatosensory plasticity. And all these things are the ones that are now implicated for subjective tinnitus. Well, please understand that a good proportion of patients with tinnitus present with hyperacusis, and hyperacusis is not developing a strong ears, but hyperacusis actually refers to hypersensitivity to muscle hearing. So there is a difference. And what actually happens is that there is an epileptic-like cortical network activity in patients with tinnitus. Now, this is speculative. We are only, I mean, this is a conjecture which needs more proof. Then can we prescribe anti-epileptics for all patients with tinnitus would be the next obvious question that would come up. This guy, I think the treatment part of it will be, and there will be a lot of discussion part of it at that time. Maybe we will discuss it at that. But the most important component is a letter written by Dr. A.G. Gordon in the Neurology 1998, when it was declared that tinnitus is all central. So there is just one line which is very important to quote here. I am unaware of a single patient with normal ears and hearing and tinnitus resulting from a proven brain lesion. What it means to say is that if there is a brain lesion, there usually is an associated hearing problem. And the vice versa is also true with regards to auditory hallucinations. And he writes there, the matter, however, can be swiftly settled by production of a one good case of auditory hallucination attributable to a clear brain lesion in someone in whom peripheral ear disease or hearing disorder has been excluded. What it means to say is that it's been the usual theory, like genes are responsible, and then what happened was, well, genes and environment is responsible. In the same way, it's not just having an infrastructure that's important, that is the central nervous system. There is some kind of a relationship between the central nervous system and the peripheral, and the hearing apparatus, the cochlea, for both auditory hallucinations and tinnitus, being a type of auditory hallucination, also has a similar give-take relationship. Okay, from monotonous theory, let's get back to something more cheerful. Here is a patient, a 72-year-old who presented with intermittent hemorrhagic otorrhea and a pulsatile tinnitus in the right ear, daily headaches, hearing loss in her right ear, and with right tongue atrophy last 3 years. So what happened? There is a lesion up here which extends to the right cerebellopontine angle and down into the jugular fossa. That's basically jugular tumor, glomus jugular. This is an external carotid arteriogram that shows that it's a very vascular tumor. They embolized, and then subsequently patient went for a radiotherapy, and this patient has done very well with and was asymptomatic subsequently, and that's what is the case report. Just to highlight that tinnitus has a treatable component. I mean, this is a very common thing. When do you observe a tinnitus? When it's bilateral for less than 6 months duration and there is no other symptom. And the patient decides, forget it. Well, Dr. Ramesha has told you all the care that you need to take, and therefore I add that as well. Spontaneous improvement of tinnitus does happen in approximately 30% of individuals. So that's the time when, if it is bilateral, yes, you can wait. But if it's unilateral, if it's pulsatile in nature, if there is an associated focal neurological deficit, or if there is an asymmetric hearing loss, then please investigate the patient, because asymmetric hearing loss, especially by audiogram, please investigate, because it is very, very important that we do not miss a treatable cause for the tinnitus. Right. Right. So, what is this tinnitus business all about? So, we've discussed two aspects of tinnitus. Aspect number one was with regards to etiologies which produce some kind of a sound. Aspect number two was with regards to that which is not so obvious with regards to producing sounds. And then the conclusion is that with regards to etiology, it can be either of the two. But understanding tinnitus, especially for the sake of postgraduates, is very easy if we were to understand the concept of how a sensory organ works as per our Indian traditions. Indriya, or the organ of the sensory organ, is supposed to be merely an instrument conveying sensation to the manas, the mind. The mind has been divided into two parts. Part one, the mind which is called as a confused mind. Part two is the mind which is called as a discriminatory mind. The discriminatory mind is what's called as buddhi. So, a relationship between the two is the buddhi interprets the confused mind and comes to a conclusion. And that is how the Atma or the person actually makes that, okay, this is the sound. Now please understand, the whole world is a Maya. Why? Because it's there only inside the mind. There is nothing that is not, that there is nothing in the world that exists which is not imperceptible to the mind. If the mind perceives something, then it exists. If it does not perceive something, then it does not exist. It's as simple as that. And that's where the fourth line in the definition came in, that it causes some emotional reaction. So that component that generates a reaction is the limbic system. That component, which we call it as a primary auditory complex, is probably your confused brain, wherein you have all different types of sounds. And that component which decides, I don't know which one that is multi-loculated, or it's present almost scattered throughout the brain, or maybe elsewhere as well. So it is an interaction of so many structures that give rise to a sensation called as tinnitus. Now, the European guidelines are very clear. What is it that you are supposed to do? The patient is supposed to visit a general practitioner, find out whether tinnitus is bothersome or not bothersome. If it is not bothersome, just forget it. If it is bothersome, okay. If it is bothersome, then refer to the ENT or the audiology department, do a complete assessment. And if there is no suffering reported by the patient, just educate the patient and leave them. If the suffering is reported, then send them to a specialist tinnitus center and do all the sorts of assessment and go for specific psychoeducation, CBT for tinnitus, and all other specific treatment that we will be discussing subsequently. But my only point is that please understand, I have shown you some very rare patients with venous stenosis, conditions that we have probably not been aware of till today, which could potentially give rise to symptoms of tinnitus. And therefore, it is mandatory to examine every patient clinically before we decide to send them to psychoeducation or CBT for tinnitus treatment. Okay? This is an European guideline. Of course, at various places, you will have to put that ifs and buts. That is, if your tinnitus is unilateral, if it is a pulsatile tinnitus, if it's associated with neurological abnormality, then there is a mandatory need for the patient to be evaluated completely. Well, I'm not going to go through this, but what's most important is what remove wax from the ear. Well, this may seem very obvious, but please understand, it's not just the wax that matters. Presence of a wax is not directly related to the etiology of tinnitus. The wax needs to ensure that it touches the tympanic membrane and prevents its movement. And that is what can potentially cause tinnitus. Now, how do you assess whether it's timed with the pulse? Ask the patient to just tap a finger as and when they hear the tinnitus, and you check it up. You are doing a clinical examination to know whether it times with a pulse. Right. Auscultation over the head, over the mastoid, over the ear canal, and over the skull is all important so that we can identify a pulsatile tinnitus. Well, this is a very nice demonstration of what Dr. Ramesh has already shown you, a glomerular tumor, which is very nicely pulsatile. Tinnitus grading, he touched upon it. Basically, the impairment component of it was already discussed. Grade 1, if there is no distress. Grade 2, if there is and no impairment. Grade 2 is impairment is occasional, but only under stressful situations, and when the patient when the environment is silent. Grade 3 in several, and grade 4 in almost all situations. Investigations. Right. Every patient with tinnitus has got to undergo an audiogram. I mean, that's a mandatory thing. And depending upon that, you do the tonometry. Tinnitometry as well, which was discussed in detail by Dr. Ramesh. And of course, all other investigations will depend upon what is the abnormality that needs to be evaluated, including dental examination, EM junction, which can potentially cause click-like sounds, a pulsatile tinnitus. So what's most important here is, I need to touch upon, is an auditory brainstem responses. We go back to our previous diagram. Basically, 5 waves, one from the auditory nerve, the second one from the cochlear nucleus, the third one from the superior olivary complex, lateral lemniscus, and inferior colliculus. I mean, these are the 5 waves that I use. Now, what is its significance? I mean, that's what's most important. It has been found that patients with tinnitus have a longer latency and a reduced amplitude of wave 1. But then there are a lot of studies, a lot of things that have been coming up. But there was no consistent results between the study of what the amplitude or what the latency difference should be between tinnitus and controls, by which you can say that this person has got tinnitus and this person does not have tinnitus. So there is some vagueness as far as the amplitude and latency figures are concerned, and therefore it doesn't make sense for us to show a patient and then decide based on that as to what is the response with regards to, or make it as one of the components for diagnosis of an abnormality in tinnitus. The last part of it, of course, is treatment. What we know of today, there has been a Cochrane review as far as tinnitus is concerned. And what's come out is that for acute tinnitus, whatever has been used, cortisone, intratympanic steroid therapy, antiarrhythmics, anticonvulsants, anxiolytics, glutamate receptor antagonists, antidepressants, muscle relaxants, serotonin antagonists and reuptake inhibitors, benzodiazepines. The recommendation is against the use of drugs. No drugs for acute tinnitus, no drugs for chronic tinnitus, underlying psychiatric comorbidity to be treated only when present, no antidepressant in non-depressed patients. Cochlear implants, as of now, whatever is blue is no recommendation, whatever is good is green, and whatever is bad is red. Hearing aids is a weak recommendation where there is a hearing loss plus tinnitus, but all other treatments, be it cochlear implant, be it neurostimulation, transcranial electric stimulation, vagus nerve stimulation, acoustic, coordinated reset neuromodulation, invasive treatments, cortical surface stimulation, deep brain stimulation, thorough. The only thing, cognitive behavioral therapy, there is a strong recommendation. There is a high level evidence for effectiveness and safety of CBT for tinnitus. Tinnitus retraining therapy, sound therapy, not much. Dietary and alternative therapies not recommended. Acupuncture, still we are not sure as to whether it's effective or not. So the areas which are still open include Ayurvedics. We still don't know what it is like. So anybody interested can potentially take it up as well. So here we are. We have an elephant in front of us. We know there is an elephant, but it's the other way around. We don't know what this elephant is. We don't know what the methodology is, how to handle it, how to go ahead with it. Yes, we can manage in certain conditions quite well. And therefore, let us at least concentrate on not missing those conditions which can potentially be handled. And, as the original author of the doctor had written, it is not that the patient wants too much from us. All that they want is a mere concern. And that helps the patient a lot more than whatever medication that we may give. So what we need to give them is a silent hearing. And I think these are two good references that I've used in my presentation, and they are good as well for people to read up. And if you were to develop a new medication, then it has got a product value of around 689 million, around 700 million in its first year of launch. 30 million people in Western Europe, United States, are actively seeking help for tinnitus, and 4 million off-label prescriptions for tinnitus were written each year. So there is a lot of money in waiting. So my request, get into research, get into potential drugs, and hopefully we will see billionaires coming up very soon. I thank Dr. Srinivasan sir for having given me this opportunity. If you have any questions that I could potentially answer, I'm happy to take up.
Ramchandran, as usual, your own style and wonderful presentation. As you said in the beginning, cardiology and ENT, we used to make a joke saying that auricle is there in cardiology and you got a ear auricle, and ventricle is there in cardiology and we have a laryngeal ventricle.
so closely related with all these things on those days when we were postgraduates. So I remembered that when you said cardiology is the main contributors for that. And also I would like to say that again, to say that the ENT people are the contributor more to the cardiologist because of the tonsillitis producing a lot of cardiac problems. So always medicine is interrelated. So, but you did a very, very nice presentation. The only thing is now I'm afraid to write even B complex or multivitamin tablets for my patient.
I mean, it is only to...
Yeah, I understand. And just for fun, I am telling. And you also said, you're sending a lot of patients to us. But unfortunately, this is the area where we do not want the patient to come. This is a lot of problem for us also. So, anyway, thanks for a wonderful, fun-filled lecture. I always know that you will, deliver what I expected from you. So thank you very much. As such, we do not have any questions, and when the questions comes, I will call you back and ask you about.
Sure.
Thank you, Ram. Oh, wonderful, wonderful way. Now, Indu will take over.
Thank you, sir. The next session for today's program is Tinnitus Management by Otorhinolaryngologist. The speaker for the session is Dr. Ramesha, sir. I kindly request Professor Dr. Srinivasan, sir, to chair the session. Thank you.
Yes.
Welcome back, Dr. Ramesh. And as we told you, we have a few questions from the last session. And can you answer them before we start?
Yeah, sure. I'll be very happy to answer the question.
Yeah. Jayashree said, what from Dr. Mohan from Bangalore, he has asked for causes for intermittent tinnitus, short duration.
Intermittent tinnitus for a short duration
comes and goes. A short duration tinnitus, for some time goes.
Yeah. It is. This type of symptoms are known to be there when the person has got an intermittent hearing loss, or even it follows a common cold, and it goes automatically. It goes off. It's not bothering symptom for the patient.
Then from Dr. Preeti from Gurkon, he said how to differentiate between a subjective idiopathic tinnitus and psychological tinnitus.
So there comes the importance of taking proper history of the patient. We have to spend a lot of time with the patient and try to find out if there are any associated factors related to anxiety. We have to rule out if there are any other sinister causes, as very nicely told by Dr. Ram in his lecture. It was a wonderful lecture. I must congratulate him for that. Very thoroughly presented material. Relation of the tinnitus with the vertigo.
Yeah.
That is
third question, Dr. Shrita from Katika. He says, what are the types are associated with vertigo more?
Tinnitus with vertigo is a commonest presenting symptoms in conditions like Meniere's disease, even vestibular neuritis. There is a association of vertigo and tinnitus. We do see cases of vestibular migraine. Vestibular migraine is known to present in all forms. You'll see all the possible combinations of presentations with vestibular migraine. It's very common. Whenever there is a vertigo associated with tinnitus, we have to be on guard. We have to investigate patients properly. We have to do the proper vestibular assessment and come to the conclusion, because these are the conditions which are treatable and we can give cure to the patient.
Thank you. Now you can start your
Sure.
presentation.
My presentation is seen. Hello.
Yes, sir. Your presentation seen. Please proceed. Proceed.
As the etiology, pathogenesis, and presentation of the tinnitus is very complex, so is the management of the tinnitus. Managing a tinnitus patient is a very complex issue, as there are many aspects which are needed to be taken into consideration. What are the obstacles? As correctly quoted by Professor Ram, we have very limited understanding of biological basis for the tinnitus. There are many postulates, many theories, and the surprising part is there is no accepted tinnitus nosology. What we have is a heterogeneity of the tinnitus population. There are many medical conditions which are causing tinnitus. So as many drugs which are used for different conditions, they are causing tinnitus. All over the world, there are so many double-blind, placebo-controlled, crossover studies and trials, etc. going on. There is a lack of a proper experimental control, and usually the sample sizes which are shown for efficacy of a few drugs in the treatment of the tinnitus, the sample size is very small. So you cannot come to a conclusion depending on the small sample size. Even though in last 10 years, there are a lot of advances are made in animal models where drugs are tried to suppress the noise-induced or drug-induced tinnitus. But again, the drugs which are used, they are to be directly applied in the inner ear or the round window, and they are studied. The role of oral medicines again is going to be a complex problem, because most of the molecules which are tested, they are not having a proper oral compositions. And of course is the cost of research. As it has been correctly pointed out by Professor Ram, there's a lot of money involved in research of drugs, and so many different molecules are tried. Young generation, it has got a very good chance of embarking in this field of research, where there are so many things those can be done. A word about the pharmacotherapy. Let me be very clear that there is no FDA approved molecule is available today. Every drug which is tried for treatment is said to be an effective one, but FDA approval is not there. Same thing is true about the European accreditation and other things. This topic I'll try to cut down because Professor Ram has covered it very nicely about the neurotransmitters which are there in the cochlea, the afferents and efferents, the inner air cells and the outer cells. There are different transmitters which are there in the excitatory pathways. There are inhibitory pathways, and there are modulatory sort of molecules which are acetylcholine, dopamine, serotonin, opiates and others. The neurotransmission as such, it's a very complex process, and whatever drugs they are tried, they are either used for different conditions other than tinnitus. They are used for other medical conditions or in psychiatric disorders or treatment of cardiac arrhythmias. And they have found that it is useful for reducing the tinnitus. But again, the sample size and heterogeneity is an issue. There are different drugs which have effect on the inner ear vasculature, the metabolic supply, different IL channels which are involved, and the neurotransmitter production, metabolization, and receptors. As we know, there are excitatory and inhibitory sort of channels, and Professor Ram has very correctly demonstrated about this axis, which is very important to understand what drug is going to act where and how it is going to be effective in managing the complex symptom of tinnitus. As an ENT persons, what is in our hand, we can diagnose correctly the otological conditions, those are causing tinnitus. Say about Meniere's disease. If you are very careful in taking history of the vertigo patients, you can clinically diagnose Meniere's disease with a classical triad of symptoms. It can be treated very well with different drugs. Everybody is aware of that. Diuretics and beta-histine. These patients also, they need a lot of counseling because the patient is not consistently ill. The patient gets sporadically, keeps on getting the attacks. Maybe the earlier attacks are severe and then the subsequent attacks are not that severe. But a lot of counseling needs to be done. And again, as I have said, that whenever there is a vertigo and there is a tinnitus, the first thing which comes to the mind of the patient is brain tumor. The fear of the brain tumor from the mind of the patient needs to be removed, and we have to properly explain them everything. There are hearing aids also which are multi-programmable, available for patients of Meniere's disease, where the masking also can be done so that the tinnitus is subdued. Many times the patient has got no hearing loss, but still if the tinnitus is bothering, nowadays the audiologists, they recommend hearing aid. There are different relaxation therapies which we can suggest to the patient of the Meniere's disease with biofeedback. Surgical options are there. If patient has got non-serviceable hearing and tinnitus is the only bothering complaint, sometimes it is intractable, disturbing his daily working, sleep. At that time, you can think of giving a intratympanic gentamicin, which is very popular these days. It has been observed that gentamicin gives relief to the component of tinnitus, and by using techniques like examination by video impulse test, you can find out if there is any vestibular damage during the gentamicin therapy. Vestibulocochlear nerve section, at one time it was very popular treatment for Meniere's disease. Nowadays, selective vestibular section is done to relieve the vertigo part. If the patient has got tinnitus as well as vertigo, you can think of doing vestibulocochlear nerve section. Nowadays, there is no need to go for the trans-labyrinthine approach. A retrosigmoid approach is used and the surgery is performed by even using endoscopes. Now, more advances in management of surgical management of Meniere's disease has opened the doors for neurosurgeons and ENT surgeons work together and give relief to the patient. A word about vestibular schwannoma. Even if it is found to be there in patients who has presented with tinnitus, we have to explain to the patient that this is a very slow growing tumor, 2 millimeter per year. Patient needs a lot of counseling, and we have to explain to the patient that even though if there is a tumor, it is sitting on one particular nerve and it is not going to expand or cause danger to the life. To relieve the tinnitus part or hearing deficit, after the surgery, there are different types of hearing aids which are available. They are either cross or bi-cross hearing aids. Contralateral Baha also can be tried. And patient can have good sort of a hearing. Even now Brainstem implants are coming, which are used in cases of operated cases of schwannomas. Even they are used when petrostectomy is done and patient can restore better hearing. We do come across many cases of sudden sensorineural hearing loss, what we call it idiopathic sudden sensorineural hearing loss. These are the cases which need early audiological intervention, correct diagnosis. A lot of modalities of treatments they are available, and so many drugs they have been tried, including intravenous steroids, intratympanic steroids, hyperbaric oxygen, carbogen therapy, where there is a mixture of 5% carbon dioxide along with 95% of oxygen is given. Nowadays, comparative studies between intratympanic dexamethasone and IV steroid, they are also available, and it has been now a sort of a standard practice to go for intratympanic steroids in cases of sudden sensorineural hearing loss. The injection can be given as an OPD procedure using a 26 number gauge needle. If you want to give repeated injections in cases of sudden sensorineural hearing loss, intratympanic route, you can put a gromate. One of my colleagues, even he has tried putting 2 gromates, because through one gromate you can instill the drug. Through the other gromate, the air which is there in the middle ear, it is going to come out, and the drug can be there for a longer length of time, and it can give good sort of an effect in cases of sudden sensorineural hearing loss, when there is a recovery as far as the hearing part is concerned, and the tinnitus also gets reduced subsequently if there is a good hearing. Now I'll go through all drugs which have been claimed to be useful for tinnitus. Professor Ram has concluded in his lecture that every drug is causing tinnitus. That is true, but the research which is going on all over the world, they have tried different drugs for treatment of vertigo, for treatment of tinnitus. So like furosemide or diuretics, we are using routinely for Meniere's disease, which is tinnitus is one of the symptom. This is a drug which used in extensively in treatment of congestive cardiac failure and edema. It inhibits the sodium potassium chloride contransporter that transports sodium, potassium and chloride ions in and out of cell, and the same sort of mechanism is expressed in the inner ear also as well as in the brain. It blocks the GABA A receptors. It was proved that cochlear tinnitus responds very well, but if it is a central origin tinnitus, it is not getting suppressed more. The tinnitus in Meniere's disease or in endolymphatic potential and other cochlear responses are very good, and furosemide as well as other diuretics, they are used in the treatment of tinnitus. There's one molecule which is amino oxacetic acid. It is used as an anticonvulsant, again a potentially inhibiting GABA T, leading to the buildup of gamma in the brain, thereby strengthening the inhibitory or afferent responses which Professor Ram has quoted. It also reduces the endocochlear potential in the cochlea, but again this drug has got severe side effects. Scopolamine we are all very well versed with. This is a common drug which is used for motion sickness to control nausea, and it is also used for controlling the intestinal cramps. This is a competitive antagonist of M1 muscarinic acetylcholine receptors, which are widely distributed in brain and along the auditory pathways. The rationale for using scopolamine is based on the fact that a high doses of salicylate significantly increase the expression of activity and plasticity of protein C-FOS and ARG31 in the auditory cortex and amygdala. These proteins are considered putative markers of tinnitus-related neuronal activity. The amygdala sends axons to the nucleus basalis, which in turn sends cholinergic fibers to the auditory cortex, and scopolamine was one time proposed to be as a treatment for salicylase-induced tinnitus, as it suppresses the expression of C-FOS and ARG31 in the auditory cortex. Saccharidine is a vasodilator, and it is believed to act by blocking the influx of calcium channel into the cells. It is mainly used in peripheral vascular disorders, but sometimes it is also used in cerebrovascular disorders, because some reports suggest that tinnitus is arising from vascular insufficiency, affecting the labyrinthine and brain in the patient with tinnitus, vertigo, and visual disturbances. People have tried 90 days treatment of the conditions, and severity and frequency of these symptoms with minimal side effects is there. But again, the data which was shown in a double-blind trial with the placebo was not very significant. A very popular drug, memantine, it is used in treatment of Alzheimer's disease. Professor Ram can highlight more about this. It has got a positive effects in depression. It acts as a voltage-dependent antagonist of NMDA receptors and reduces excitotoxicity by preventing prolonged influx of calcium, and blocks serotonin, that is 5-HT, and nicotinic acetylcholine receptors. This drug is used in treatment of tinnitus. The doses we have to decide in consultation with the neurophysician, because as an ENT people, we are not very much well versed with the drugs which are used in neurological or psychiatric disorders. Something about AM101. At present, a clinical trial is going on by Auris Medical Company. That's why the name is AM101. It is supposed to be a non-competitive NMDA antagonist, and a double-blind randomized placebo-controlled phase 2B trial is going on. This drug is used as an intratympanic route, and the study in patients with acute tinnitus, which is arising from noise or trauma or sudden hearing loss, who have not responded to the steroid treatment initially, they are getting benefited out of this drug. But again, we have to wait for the results, and the drug is launched in the market. About alprazolam, it's a very short-acting trizobenzapine used in treating of anxiety, panic attack, and depression is used by many people in treating tinnitus. The problem is addiction. Acetoprosate is a blocking glutamatergic N-methylene diaspirate, that is NMDA receptors, and it enhances alpha aminobutyric acid GABA mediated nerve inhibition. This particular drug is used in treatment of alcoholism, used in doses of 300 mg 3 times for 90 days in noise-induced tinnitus, had shown some improvement in patients. There's a molecule which is carovarin. It is a spasmolytic drug and acts as an antagonist of calcium and non-NMDA and NMDA glutamate receptors. It is given as an IV, 160 milligrams in a 100 ml saline, a slow infusion. At least for 3 days it has to be given, and then watch for the improvement in the symptoms. The tinnitus loudness, that is a 5-point scale, tinnitus matching, that is intensity and frequency, they are measured before and after treatment and 1 week after the treatment. Now I'll come to something which is very popular. It is a tinnitus retraining treatment. Professor Ram recommends it to be in blue zone, but this is some hope for the patients where the medical line of treatment is not very effective, and the audiologist does a tinnitus matching for 2000 and 4000 hertz, loudness of 50 dB in decreasing order, and finds out the exact sort of a frequency of the tinnitus which is there in particular patient in decibels. And then a masking sound with 20 decibel plus is fed to the patient for 30 seconds first sitting in increasing order of 60, 90 and 150 seconds. That is day 1, 3, 8 and 15. This gives some relief to the patient. It may not be curing the tinnitus, but it definitely has got a role. There are now softwares which are developed with natural sounds, like a sound of a flowing water or sound of rain, different natural sounds which we come across in our environment. And the masking is done using those particular sounds. There is a tinnitus trio hearing device, which is acoustic neuromodular transmitter therapy in a smartphone, which is developed by Professor Shahnawaz. It is also found to be useful in cases of intractable tinnitus people. It is a software which can be downloaded by patient and patient can use it at home. Then we have got a tinnitus masking hearing aids. They are beneficial in patients of mild or moderate tinnitus. What are different drugs? There are different drugs which are proving trials since 2011 to 2018. Drugs by GSK, Vestibular, by Merck's Neuromyxine, the one which I told you about,
Check up your audio, sir. We are not hearing. Dr. Ramesh, check up your audio. We are not hearing anything.
Hello, sir. Sir, our Ramesha disconnect ஆயிடுச்சு sir.
அதான் டிஸ்கனெக்ட் ஆயிடுச்சு. ஒரு ஃபோன் பண்ணி பார்த்து சொல்றேன்.
Okay, sir.
Please wait, some problem with his end. He's got disconnected with C.
Okay, sir.
Sorry for the interruption. Dr. Ramesh, internet connection went off. It's come back again. He's joining shortly. Please hold on.
My screen is seen. Hello.
Yes, sir. Yes, sir. Your voice and video and audio are visible. Please.
Yeah, there was some trouble with the internet connection. It got disconnected like it had earlier in my earlier talk. It got suddenly off. I was talking about the drug which is Diazepam. It is popularly used by many people. It's a benzodiazepine used for insomnia, epilepsy, and muscle spasms. It has got a specific binding with the GABA receptor. It is a positive allosteric modulator of GABA that increases the hyperpolarization and decreases the neuronal excitability. In low doses, definitely it can be tried. Clonazepam is a very popular drug which is used. It's again a benzodiazepine which is used as a muscle relaxant, anxiolytic, anticonvulsant. Like all other benzodiazepine, it binds to the GABA receptor site and helps by leading depolarization and decrease excitability. There are molecules which are tried like vigabatrin and tiagabine. These are the true drugs which are having GABAergic action, the drug which are used as an anticonvulsant. They are supposed to be beneficial in treatment of the tinnitus. These are the drugs which are actually used for seizures and panic disorders. They are to be used with a loss of inhibition in the CNS, as it is the result of cochlear deafferentation, which was very nicely told by Professor Ram. Either it is caused either because of the noise or aging or ototoxic drugs. There is a definite hope for trying these particular drugs. Of course, with the help of a neurophysician colleague, as we are not very well versed with the doses and the side effects, etc. A word about lidocaine. It's a xylocaine which is used as a local anesthetist in treating cardiac arrhythmias also. One of to the voltage gated sodium channels, it reduces the magnitude of the sodium current during the depolarization. How it works is very complex, but it definitely affects the calcium, potassium, and glycine induced chloride currents at a macromolar concentration IV. Depending on the type of the symptom and the duration. Carbamazepine is anticonvulsant, mood stabilizer. It is used in variety of clinical disorders, including epilepsy, bipolar disorders, schizophrenia, pain, and in trigeminal neuralgia. During clinical trials, this drug was particularly found very useful in a tinnitus, which the patient described as a typewriter tinnitus. A big sort of a group was tried about this particular drug, and there was a good relief. The sodium valproate or valproic acid, it is used in the treatment of seizures, bipolar disorders, mood disorders, depression. It has a broad spectrum of action like inhibiting GABA T, inhibition of histamine, blockade of voltage gated sodium channels, and T type of calcium channels, and is found to be useful in few cases of tinnitus. Gabapentin is something which is widely used for the treatment of seizures, neurotopic pain, migraine. Because of its structural similarity to GABA, gabapentin was thought to be binding to the GABA receptors. However, the mechanism of action is not fully understood. Timiprine. It is classified as a tricyclic antidepressant. However, the mode of action differs from other tricyclic antidepressant, that it is a weak to moderate inhibitor of non-epinephrine and 5-HT receptors. However, it blocks some dopamine and 5-HT receptors and alters the concentration of dopamine and 5-HT, giving relief to the patients of the tinnitus. Nortriptyline, again, is a tricyclic antidepressant that is used to treat chronic fatigue, migraine, chronic pain. The primary mode of action is to inhibit repurg of the non-epinephrine and lesser extent 5-HT blockage, muscarinic receptors blockage. In small single blind placebo washout study involving patients with
Dr. Ramesh, your voice is breaking.
Hello, sir. Sir, again our Ramesh disconnect ஆயிட்டார் sir.
அதான் ஏதோ வீட்டில் இன்டர்நெட் ப்ராப்ளம் போல இருக்கு.
Okay.
Hello.
Yes, sir. Proceed.
Yeah. This is one very, I'm extremely sorry for the interruptions.
Happens.
These molecules which are there, which are used in different sort of entities, like they are antagonists of tachycline N1 receptors binding to the substance P. It acts as a neurotransmitter and neuromodulator. Neurokinin receptors are present both in inner ear, and therefore it represents as a potential therapeutic target for tinnitus. It is an SSRI which is used in depression, obsessive compulsive disorders, and anxiety. A word of caution to all my friends, those who want to use different drugs that are routinely used by neurophysicians or psychiatrists. We have to tell the patient about these drugs, because now the patient, they have got access to the internet. They try to find out everything about whatever molecule we prescribe to them. So we have to be very honest to the patient and tell them about what is the basic drug, where it is used, and we have to tell them that this is found to be useful in the treatment of tinnitus. Sertraline, again, it is a major antidepressant drug used in obsessive compulsive disorders and panic disorders. It mainly acts as an SSRI by suppressing the serotonin receptor. However, it inhibits the dopamine transporter and receptors for depression, anxiety, and high risk of developing severe tinnitus, in fact. But again, it was shown to be effective more than placebo in reducing the tinnitus loudness, tinnitus severity. No relief for the tinnitus, but definitely the annoyance was reduced. And collectively, the results for the tinnitus patient with depression and anxiety, these patients may get benefit from the antidepressant treatment. Misoprostol is again a synthetic prostaglandin E1 PGE1 analog that is primarily used to prevent gastric ulcers induced by non-steroidal anti-inflammatory drugs such as aspirin, and also it is used in inducing labor that inhibits inflammatory cytokines in patients with hypertension and or diabetes. The decrease in the tinnitus was found to be significantly more greater in trials with this particular drug. Atorvastatin, Professor Ram has touched in his presentation. Cardiologists, they prescribe this drug very often, and it causes tinnitus. It lowers the blood cholesterol and prevents the stroke. It suppresses the production of the melatonin and in reducing the synthesis of cholesterol, but it improves the circulation and reduces the inflammation and oxidative state. In a 13 months randomized double-blind placebo-controlled study involving elderly patients with elevated cholesterol, it failed to show any improvement in age-related hearing loss, but it also did not significantly reduce tinnitus. At one time, it was thought to be useful in reducing tinnitus, but as Professor Ram has correctly pointed out, this drug itself can cause tinnitus. Ginkgo biloba is tried for everything, and it is tried for tinnitus also. It is a ancient Chinese plant sort of a thing, and a Ginkgo biloba tree. It has got different roles like vasodilatation, antioxidative properties. It is used in wide variety of disorders, including tinnitus. There are several studies that are going on with this particular drug, particularly in patients with short duration of treatment. One, behavioral studies with rats, it has found that EGB 761 reduced the behavioral manifestations of salicylate-induced tinnitus. This was tried in animal studies, but however, there is a growing body of evidence that large, well-controlled, double-blind, placebo-controlled clinical studies, they clearly indicate that it is not that effective in alleviating the tinnitus symptoms than placebo. Melatonin, it is a circulating hormone which is produced by pineal gland and other tissues that binds melatonin receptors and plays an important role in regulating the circadian rhythms. The jet lag which we suffer is because of the disturbances in the circadian rhythms. The melatonin also is a potent antioxidant, protects the mitochondrial and nuclear DNA. It is found to protect against the noise-induced and drug-induced hearing loss. Because of the sleep disturbances, it represents a major complaint factor in the tinnitus. Melatonin was evaluated as a treatment for tinnitus in 3 different studies. And in a double-blind placebo-controlled crossover studies, score of tinnitus severity measured with tinnitus handicap inventory, it was found to be same as with the placebo, but there was a trend towards improving sleep scores. Subsequent open label study found that it is significantly improvement in the tinnitus handicap inventory. There's a Petersburg sleep quality index with melatonin treatment. However, it is very difficult to evaluate that these findings are because of a lack of placebo control group trials, and the group size are very small, and more trials they are awaited. Zinc supplement, now again in vogue in this COVID situation. It is an essential trace element which is found to be useful in numerous biological functions, widely expressed in auditory pathways, including the dorsal cochlear nucleus, a structure poised to be a major tinnitus generator. Zinc has been proposed as a treatment for tinnitus, particularly in patients with hypozinkemia. While positive results were reported in some patients, most well-controlled double-blind placebo-controlled studies have found to be very little use as compared to the patients who had a low zinc serum levels. A dietary supplement trial still is underway, and we are waiting for more results. Varnaphenylene is a drug which is again inhibitory sort of a role in cyclic GMP cycle. It was found that a very small sample size of 21 patients receiving placebo or varnaphenil, tinnitus questionnaire, tinnitus loudness and pitch, and other audiometric measures, they failed to reveal any clinical or statistically significant values in these drug trials. Gaciclinidine is an NMDA antagonist under evaluation for the treatment. Large animal studies are going on, and preliminary studies in unilateral deaf human being, perfusion of this drug on a round window for several days, it has found to be useful in temporary relief of the tinnitus. Potassium channel inhibitors, modulators, they are supposed to have roles in a neuronal hyperactivity. The potassium channels, they play a very important role in regulating the resting potential and spontaneous evoke neuronal activity. Potassium channel modulators, they represent a potential therapeutic targets for tinnitus therapy. They have been also attracting as a potential therapeutic target for pain, epilepsy, anxiety, and hyperexcitability disorders. Sulpiride, it is an antipsychotic drug which is blocking a selective dopamine D2 receptors. Several studies have explored the use of sulpiride to treat tinnitus based on model and data suggesting dopaminergic pathway in limbic, prefrontal, and temporal areas of cortex. They contribute to the tinnitus severity. However, again, the combination of sulpiride, which interacts with dopamine receptors, reduced tinnitus visual analog score significantly more than placebo. Carbamazepine, I have already told you about a role in typewriter tinnitus. It is used in trigeminal neuralgia, epilepsy, bipolar disorders. It binds to the voltage gateway gated sodium channels and stabilizes neuronal firings. Used in doses of 600 to 1000 milligram per day. So the take home message, it is possible to treat tinnitus. We have to subtype the tinnitus for a successful therapy. Lot more work needs to be done in the field of evaluation, different subtypes, management of different conditions, and different drug trials. A summary of pharmacotherapy, which I have put in a nutshell after studying many articles and trying few of them in my own patients. Where to subtype a tinnitus, if it is a recent onset tinnitus for less than period of 2 years, ginkgo biloba and trimethadone can be tried. If tinnitus is associated with dizziness, beta-histine is definitely hopeful. If there are somatosensory tinnitus, cyclobenzapine are useful. Tinnitus with cognitive impairment, memantine is definitely a hope. In cases of noise exposure and tinnitus, gabapentin and memantine, they are useful. Insomnia associated with tinnitus, melatonin is the answer. And general tinnitus, again, clonazepam given for a short duration of time is definitely useful. Thank you very much. There is one particular book I like to recommend to the juniors. Is a tinnitus treatment. It's a book by Thyme Publishers. A very exhaustive information about the different protocols, different modalities used in the treatment. So we can come to know what is going on all over the world. My sincere thanks again to Dr. Srinivas and the organizing committee of 7th, Dr. Prahlada from Chitradurg, Dr. Srinivas Dorasala of Bangalore, and Professor Shah Nawaz of Bangalore. Thank you very much.
Thank you very much, Dr. Ramesh. Now,
is there any questions?
Yeah, we have. Sir, your questions have not yet come. I'll see it. I asked Ramchandran phone. Ramchandran, are you there?
Yes, sir.
Questions for you. Dr. George Thomas from Coimbatore has asked you, how do you account for the role of neurotransmitters in the generation of tinnitus, also the part of endorphins at the cochlea?
I mean, can the person who raised the question?
Please, you get it.
Yeah, the thing is that, I mean, there has been extensive study with regards to neurotransmitters that are involved in the auditory pathway and elsewhere transmission. And this is one of the reasons why I brought up this analogy between seizures and tinnitus and auditory hallucination as one of the potential mechanisms that opens up the market as far as potential anti-tinnitus drugs is concerned. The way you look look at tinnitus makes all the difference with regards to what you could potentially do. There has been lots of review about it, but as of today, I don't think we have one medication or something which can actually put a tab and say that this is what is actually happening. It's not as classical as in Parkinson's disease for us to say that do this, give a dopamine agonist, and you are much better with regards to the motor improvement. Even now, even Parkinson's now, the concepts are fast changing with regards to mere dopamine insufficiency. We are of late starting to realize that most of these conditions happens because of network issues, and these networks involve not just one neurotransmitter but also many others as well. So it is mere, I think we are looking at targeted therapy for individual patients. I mean, very shortly we'll come to a state wherein we'll start prescribing Ayurvedic medicines to our patients. That's my honest feeling. I mean, one thing may not really work the way as others. But anyway, I mean, please hold on. More of this could potentially come in the evening lecture on recent advances. So I don't want to step in before that.
Again, George Thomas Coimbatore. He has asked, research and development should focus on efferent cochlear pathway. Very little work has been done in this inhibitory mechanism. Your opinion regarding the generation of tinnitus pertaining to this mechanism?
See, I am more the thread in the garland rather than the flowers in the garland. So what I have done is my objective was to give a presentation on the concept of tinnitus for the postgraduate level. If you want it at a research level, I think my knowledge is very insufficient to actually give you answers to that. I accept, of course, there are growing thoughts on both sides. Whether efferent should be looked at or afferent should be looked at, both is going on simultaneously. I accept that. I don't deny that fact. Yes, efferent is one of the hypothesized mechanisms as far as production of tinnitus is concerned.
Now, another question from Dr. Ganesh, Chennai. A case of unilateral continuous intractable tinnitus male for 5 years. No comorbid condition. Otoscopic examination is normal. PTA is moderately sensory neural hearing loss. Radiological and neurological examinations are normal. How do you proceed?
Yeah, because it is unilateral, there is a very good chance that you can potentially find an abnormality. The first question is the patient distressed or not? Okay, I mean, that's what your guidelines actually says. If the patient is otherwise normal, even if you detect an abnormality, many times you may not need to treat the abnormality as well. So that's true even for tinnitus. If the patient is distressed, then you of course go about to find out whether one of those rare causes does exist. Examination is normal, so do a neurological assessment as well, along with an angiogram, to find out whether there are any abnormalities that could potentially give rise to this sort of an abnormality. If there are none, then again you go back to the scheme of the European recommendation, okay, to either to CBT or one of those associated treatment. Yeah.
I'd like to add something. I fully agree with what Professor Ram has said. If there is any moderate or mild sort of a symptom and you don't find any abnormality, either ENT wise or you do investigations like MRI and everything, and if there is no abnormality, don't be very aggressive in treating this particular patient.
As he said, it's a symptom. It's not a disease.
Yeah, you don't be very aggressive.
You find a disease, no, it's very difficult to treat a symptom, right? So symptomatic treatment, as we call that.
Yeah.
Paracetamol.
The problem with tinnitus is that there is good comorbidity associated with it. And therefore, evaluation of that comorbidity, basically psychiatric comorbidity may be associated with it. And I think, that is a part that's going to come up in the discussion shortly. And it doesn't, immediately mean that you barge in. I was afraid to use the psychiatric comorbidity part of it because once you say that, people immediately get a feeling that, oh, he's calling him mad.
No. That should not be the case. I'll add something, Professor Ram. In one of our national conferences, we had one speaker from France. And in France, the tinnitus is treated by psychiatrists. It is not treated by either neurologists or even ENT people. I was very impressed with whatever talk he gave. He gave 4 lectures, and they were very, very exhaustive lectures on this particular topic. And that's how the relationship of the no relief for the patient in spite of whatever treatment we give. There has to be something which is prohibiting by getting relief to the patient. And we treated jointly, myself and one of my psychiatrist friend, we treated jointly a few patients, and we have got very good results. When you tell the patient that you have to go to a psychiatrist, I give them an example. I wanted to give up smoking, so I went to psychiatrist.
Yeah, what you say is absolutely right, Professor Ramesha. I totally agree with you. But in a forum like this, in a webinar, wherein we don't know who are the real people listening on to the other side, you have even family members listening up there.
Yeah, it doesn't matter.
They should not get a wrong information of what we say, and we got to be very careful when we reveal information. Whether we know or we don't know is a different story altogether.
No. If it is the moment you tell patient to go to a psychiatrist, they are afraid.
Yeah, that's precisely.
They are very reluctant to go to a psychiatrist.
That is our cultural. That also we should know. As he said, as soon as he says psychiatrists, they are thinking, pulling their head out and hats out and tearing their shirts. That is what runs into that.
The concept of people going to psychiatrists is different in our country.
More than that, they immediately think, doctor, do you think I am mad? That is the syndrome that comes up.
So that's the reason I tell them.
You are telling me that they are tearing the shirts out. That is that. That should change.
I agree.
It's going to be
I agree with you.
Ram, you have got one more question. Can you highlight more on the presynaptic differentiation of the ganglion cell causing tinnitus?
Unless and until I know the logic from where this comes in, it's a difficult question to answer for me at this point in time. Yes, I can tell you differentiation. I did discuss about this. I told you also about experiments that have been conducted in noise-induced hearing loss, wherein animals which have been subject to it, and then when you look into the cochlea, I said that yes, the inner hair cells are very well preserved, whereas it is the synapses which actually degenerate, and that is the one where you have all this sort of presentations happening, is what I said it. But if you want me to explain each and every step as what's happening, maybe that would require. I don't think I would be prepared for that at this point in time.
Thank you, Ram,
thank you, sir.
Coming back and facing this VOC. Thank you.
Thank you very much, sir. Thank you.
Now, Dr. Ramesh.
I'm very much sorry for the interruptions which are there because of the internet connection.
Yeah, sir. I was there for quite some time, and then after the internet got disconnected, I just left. Your presentation was excellent, sir.
Thank you very much, sir. Thank you very much.
Now, Now, Ramesh, your questions.
Yeah.
My resident will read out. I have written this small letter.
Good afternoon, sir. Dr. Narendra Suratwala from Surat has asked how one improves cognition to relieve from tinnitus.
Can you repeat the question?
Yes, sir. How one improves cognition to relieve from tinnitus.
The cognition therapy, which is used for tinnitus, helps in interpretation of the tinnitus for the patient. The person who is giving constantly attention to the tinnitus can, be diverted, and this can help. My friend who is going to give a talk in the latter part of the seminar, he can tell more about the cognitive behavioral therapy. The different roles of these particular modalities, it has been tried in patients, those who are refractory sort of for the treatment in tinnitus. Cognitive behavioral therapy definitely plays a role in modifying the patient's response to the tinnitus.
Can I make a small, explain to them how it happens?
I hope I answered this question.
Can I, with the permission of the chair?
Yeah. You please go ahead, Ram.
Okay, it's very simple. When you are with your girlfriend and you are involved in talking with her, and it's time for lunch, you don't feel hungry. When you are in a conference like this, I'll be unfair. I will not do that. When you are in very a place where you are too embarrassed to be present, and you just finish your breakfast, then you probably, or say you are traveling, you wish to eat something at that point in time, and then you go on buying one after another in order to satisfy your tummy. You're not hungry, yet you're eating, This is what is the basic concept I told you about Maya. The world exists because of your mind. And the mind does only one activity at a time, in most people. And therefore, when you are involved in one activity, then you neglect the other activity. And that's one of the reasons why you get tinnitus when you are alone and in a silent place, than when you are busy doing something else as well. You will not notice it at the end of the day. It's only when the mind is involved with the organ of sensation that a perception actually happens. Otherwise, you don't perceive things. Okay, so that's the basis for most things that are recommended.
Okay, sir. Next question is from Vardhini from Kadapa. Does multivitamins like BC have role in treating tinnitus?
Dr. Ramesh.
Dr. Ram.
Dr. Ramesh. Ramka.
Yes, sir.
Dr. Ram.
Yes, sir.
No,
is it for me?
No.
Dr. Ramesh?
It's for Ramesh.
Yeah.
Ramesh. Ramesh sir is left, got disconnected again. Disconnected again?
Yes, sir. Ramesh sir disconnected.
Yes.
Okay, I think we'll break now, and at 1:30 we'll join again. 1:30 we'll come again. I told that Sun Pharma people that they can occupy this time. If they are having something to put on, they can play those times. At 1:30, the session starts with management by audiologist by Miss Sharanya Gunal. That will be Now we'll close for the lunch. At 1:30 we will start again with the talk by Ms. Sharanya Gugnalan on management by an audiologist, and then it will continue. So till 1:30, the Sun Pharma people will, putting on some materials for from their company. Thank you.
Thank you very much.
And thank you.